Hope Cook with Dermcast.live. I am so excited to have the amazing, extraordinary Dr. Lisa Swanson, the international expert in pediatric dermatology.
That's very kind. Thank you for having me.
She's a little squeaky, so bear with us.
Is a little squeaky, recovering from a little bit of an illness, but full of energy.
Yes.
Just the same. Yeah.
Okay, so you said this, and I've noticed it just a little bit, not being in pediatrics, but we're seeing a lot of pediatric psoriasis.
Yes, quite a bit. In fact, I've been in practice for 14 years. And when I first started, I would see one new pediatric patient a month with psoriasis. And nowadays, it's one every day. And it's been true for the past 6-7 years.
Wow.
And it's true not only here in the United States, it's been a worldwide phenomenon. And I think it's part of this overwhelming increase in the incidence of inflammatory and autoimmune diseases that we're seeing not only in dermatology, but in other fields of medicine too. These sorts of inflammatory conditions have seemed to be skyrocketing.
What do you think's causing it?
I know. There are several theories. The two most popular theories. One is that it has to do with our gut microbiome as a species, that changes have happened in our gut microbiome over the past decades and maybe even centuries that have created a more pro-inflammatory state. In fact, there are even companies out there that are marketing the perfect poop for things like poop transplants, which are approved to treat things like C. difficile. And I wonder if one of these days, 5-10 years from now, we'll be sitting here, Hope, we'll be talking about the latest advancements in poop transplants for the treatment of alopecia areata, vitiligo, psoriasis. I could see things like that coming. And when I think about it, I can't help but think of mottos for these companies, just like the ideas just flow out of me. It's like, we're the shit, or our shit don't stink. You know, it's just, there's so many ideas, so many ways you could go with that.
Right. But for anybody listening, it's not available. Don't come see Dr. Swanson for a poop transplant.
Yeah, I definitely don't want to encourage a lot of visits to my clinic inquiring about this therapy. It's not something we're offering now. But the other theory about this increased risk of inflammatory diseases is that it has to do with climate change. That as our air quality decreases on our beautiful, wonderful planet, our oxidative stress on our skin and things like respiratory tract is increasing, which creates this burden and this stressor, which then our immune system reacts to. And I think both of these things actually have a lot to do with one another. There was a study showing that the food grown on our beautiful planet is decreasing in quality. And it's because as CO2 levels rise, the quality of the food we grow decreases, which then in turn could have an effect on our flora. So I think it's likely both of these things, and maybe even other things we're not even thinking about yet. But honestly, it couldn't have happened at a better time, because we have so many tools in our toolbox that can help us deal with this rise in inflammatory and autoimmune conditions. So thankfully, we're prepared. We're prepared to handle it.
Yeah, so even if we don't know exactly what's causing it, we don't know exactly what to do with our diet, we can at least treat it once it happens.
Yes, definitely, definitely. Yeah.
And so which biologics, well, we'll talk about topicals first. Tell me which topicals you use for your pediatric patients for psoriasis.
So pediatric patients for psoriasis, I still generally start with topical corticosteroids as a starting point. You want to try to get it better quickly, and they definitely work the fastest of the topicals that we have available to us at this point in time. I will often use topical calcineurin inhibitors for areas like face and folds. Psoriasis on the face is actually really common in kids. We don't see that much in adults, but it's very common in kids. And so it's not infrequent that I'm treating a kiddo with psoriasis on their eyelid. And so the topical calcineurin inhibitors do a wonderful job. And psoriasis in kids loves the underwear area. Loves it. So when I see a patient who comes in and they have obvious psoriasis on their scalp, I'll commonly say, do you have any other rashes anywhere else? And they'll say no. And then I'll say specifically, some people with psoriasis will get it in the underwear area. Have you noticed any rashes there? Because it's not often something they're going to volunteer. And sometimes they're at an age where their parent is not necessarily examining the area. So I find you really have to ask them to find out it's there. And the TCIs do come in handy for that neck of the woods too. Moving on from that, I typically will use topical roflumilast, the 0.3% cream, and it works quite well in a once daily non-steroid preparation, and so that's very exciting. I also have started to use a little bit of the roflumilast 0.3% foam, which is approved for seborrheic dermatitis, so of course you have to be cautious with your documentation, but it's approved all the way down to the age of 9, so it's something that we can use even in our pediatric patients. I look forward to using tapinarof in kids, but currently it's approved age 18 and up, and so it's not necessarily in our topical wheelhouse for pediatric psoriasis yet.
Gotcha. Do you have a favorite topical steroid for the face when you do?
I typically will keep it real simple, and I'll have them use hydrocortisone 2.5 twice a day for the first week, and then transition to the TCI.
Okay, gotcha. And what about, pimecrolimus? Do you still?
Yes, and I probably do more pimecrolimus than I do tacrolimus. I think it just has to do with access in my neck of the woods.
Same.
Pimecrolimus is very well covered. Tacrolimus I typically have to fight a bit more for. Who knows why, but so I probably find myself choosing that more in the TCI category.
And do the parents ask you about vitamin D?
They do ask about vitamin D. Do you mean like getting it from sunshine or
taking it?
Taking it like as a supplement?
Yes.
Oh, that's interesting. Actually, I haven't heard that so much. I have had patients ask me and parents ask me like, oh, we read that sun helps psoriasis. And so during warmer summer months, yes, I think that's appropriate. Of course, tell them I don't want your child to sunburn. You know, I'm thinking 15 minutes outside without sunscreen. Do that 2 or 3 times a week. I don't want them just like, out there bathing and getting sunburn. But I think sun can help. I would not be convinced that vitamin D would help. Interestingly enough, there have been a couple studies using vitamin D in atopic dermatitis, which is interesting. I also haven't been a huge adapter of that, but that's in our literature a little bit, just a sprinkle of it. And then we have our calcipotriene vitamin D analog topicals. I don't prescribe those very much. I don't tend to think that they're very effective. So that's not something in my toolbox I reach for often.
Gotcha.
Yeah.
What about probiotics? I know parents ask you all sorts of gut questions.
So I think that a probiotic can be worth a try, and I don't think there's any harm in giving it a whirl. I think that flora is impactful, but I'm almost tempted to believe that it's impactful in a way that it is triggering a more pro-inflammatory state. And I'm not sure that we can really normalize that with an oral probiotic.
Yeah.
Plus, we don't really know what exact part of the flora is the issue.
And there's so many to choose from.
There's so many to choose from. And so I'll say if you want to try it, go for it, I will sometimes recommend fish oil or just eating fish once or twice a week, because I think there has been pretty good evidence of that improving psoriasis. So I will sometimes throw that out there. Most of the time the kids make a face. They're like, that doesn't sound good.
Yeah.
I'll use the cream.
Yeah. Okay, and biologics for kids. Will you go over which ones you use, the ages?
Yes. So we have 4 biologics approved in our pediatric patients. Etanercept is 4 and up. And then ixekizumab, secukinumab, and ustekinumab are age 6 and up. And we also recently got the approval of apremilast in kids. The pediatric dose is not manufactured yet. It's not available yet. So that's held back its launch a little bit. But technically, apremilast is now approved down to the age of 6 as well. Okay. I would say in the clinic every day, seeing kids with psoriasis, I'm most likely to choose ustekinumab first, simply because it's been around a nice long time, very comfortable with its safety. Its shots are infrequent, and its shots are super easy. It's low volume, thin liquid, easy breezy. And so I tend to start with that. And if that fails, I would say most of the time I'm going to proceed to ixekizumab at that point in time. There are circumstances where I might recommend just starting with ixekizumab, and the biggest circumstance there is nail psoriasis. I think it's well proven that ixekizumab is the best at nails. Yeah. And so if I have a kiddo with psoriasis and their nails are atrocious, I will present that as an option as first line because of the nails. And also because we know that nail involvement with psoriasis can be a window to potential future issues with joint
Yeah.
involvement. And then ixekizumab is great at that too. So that would be one situation where I would present ixekizumab as first line.
Gotcha.
Yeah. But its shots are once a month, and so just a little bit more of a big deal for kiddos. The one real positive that came about is ixekizumab became citrate-free. So the
Yes.
shots hurt so much less. When it was initially approved in kids back in 2020, it was kind of hard to use because the
Yes.
shots hurt so bad.
Yes.
And so now seeing it be citrate-free has made it much better.
Yes, definitely.
Yeah.
What about topical JAK inhibitors?
Yes, for psoriasis. So I haven't used topical Rux for something that I know is very clearly cut psoriasis. Not because I've been avoiding it, but because I think we do have a lot of great therapies. And so I haven't been in a situation where I'm like, man, I'm really out of options. I'm going to go ahead and do this. But I have used topical Rux in cases of eczema psoriasis overlap,
Yes.
which is very common in kids. And that's where they have an area of their body that looks like eczema, and then another area of their body looks like psoriasis. And you're like, which one is it? And so I will commonly use it in that patient population, especially for those patients who are 12 and up. And I find it very effective in those situations.
Yeah.
Yeah.
Okay, what about screening for irritable bowel?
So I don't, or you mean inflammatory bowel?
Inflammatory
Probably.
bowel.
So I don't screen all my patients. We know that patients with psoriasis are at increased risk for inflammatory bowel disease. I will talk about screening if I'm going to start an IL-17 inhibitor, because we know that we do see some patients in these studies on ixekizumab and secukinumab that develop inflammatory bowel disease. The exact relationship is hard to really understand. I think most of us assume that we have this predisposed patient population that's more likely to get inflammatory bowel disease, and that these IL-17 inhibitors don't treat inflammatory bowel disease like our other medications do. Ustekinumab does, guselkumab does, risankizumab does, adalimumab does. And so all these other agents for psoriasis, if you did have some simmering IBD, they're going to treat that too.
Yeah.
And so because the IL-17s don't treat it, we end up seeing it pop up in those studies. I think that's the most common perception of the issue. But I still want to be careful, especially with a pediatric patient that maybe hasn't had time in their life to really declare themselves as having IBD and might have difficulty, even if I ask them questions about symptoms, might have difficulty in assessing those symptoms. And so prior to starting an IL-17 inhibitor, I will commonly do 3 labs. I will do a CBC to evaluate for anemia, a CRP to evaluate for inflammation. If all they have is psoriasis, the CRP should be normal. If it's elevated, that can imply simmering psoriatic arthritis, being obese can actually raise your CRP, and simmering inflammatory bowel disease. And then I'll also check a fecal calprotectin level, which is a test done on a stool sample, so non-invasive. And calprotectin is secreted by neutrophils in our gut. So if there's a bunch of neutrophils going crazy in your gut, that's going to be elevated. And so that's an easy test to do just to make sure we're doing our due diligence.
Yes. And then strep, if they have strep-induced psoriasis, is there a
Yes.
difference in your choice of therapy?
Yes, so with strep-induced psoriasis, it tends to be relatively explosive in its onset.
Yeah.
It commonly presents with a guttate phenotype, but it can be plaque, but just it's all of a sudden. It's all of a sudden. It's like a storm of psoriasis. And so when I see that, then I will have them go to their pediatrician for a strep test. And if the strep is positive, very important to treat that. What's interesting is that in order for the psoriasis to get better, you do need to identify and treat the strep. If you don't identify and treat the strep and you just throw steroids at it or whatever, it's not going to get better. The strep is going to continue to drive it. But treating the strep is not the only thing you need to do to treat the psoriasis.
Yeah.
But it's like putting out the match that started the fire. If the match is still burning, it can still start more fires. So you got to put out that match. And so a lot of my patients with this situation, they're completely asymptomatic from their strep. And when I mention it to families, I'm like, we should, sometimes strep's the trigger. We should have little Johnny go to see the pediatrician and have a strep test. They're like, no, he feels fine. He's not sick. I'm like, I understand that, but sometimes it's asymptomatic and it'll keep things going. And so important to address that.
Yeah.
Now, typically, if I see strep-induced psoriasis, I will treat it to begin with largely the same way. Start with topicals, move on to systemics if we need to. With guttate psoriasis, it tends to take 3 potential courses. One potential course is it happens, you treat it, and never happens again. Mm-hmm. The second potential course is that it happens and it becomes recurrent. And that's very common in people where strep is the driver. They'll get their guttate psoriasis every time they have strep. And the third possible course is that it progresses to regular plaque psoriasis. And it's really a third of patients. So I'll treat the patients, make them better, and then say, okay, we'll see it if it pops up again, and just see what happens over time.
And do you treat how long do you treat with antibiotics?
With antibiotics, typically 7 to 10 days.
Okay.
Yeah. I usually look up in my Hippocrates app what the going treatment plan for strep is.
Yeah.
A lot of times also because I'm sending the patient to the pediatrician for the strep test itself, sometimes they'll just treat them because they'll see the culture come back and then they'll send in a prescription.
Okay, so you don't do a strep antibody blood test?
I don't. I have on occasion, but I don't find it to be as definitive as a test. Yeah.
Okay. Do you have a specific biologic you like with strep, like guttate psoriasis?
I would say, so sometimes with guttate psoriasis, using an IL-17 inhibitor and using it for 2-3 months often can produce incredible results and often just puts it out. Yeah. And so occasionally I will mention that. However, I will say that with phenotypes like guttate psoriasis, they tend to respond pretty well to topicals and encourage a little bit of natural sunlight. That always helps with guttate psoriasis as well.
Yes. Okay, for pediatric patients, do you do the same screening labs as you do with adults?
Yes, in terms of like baseline CBC, CMP, that sort of thing.
Yeah.
Yes. So in kids, they're more likely to be otherwise healthy. So I would say typically with the pediatric patient population, prior to starting a biologic, I will typically just do that CBC, CRP, and the fecal calprotectin if I'm starting an IL-17 inhibitor.
Okay.
If I'm starting ustekinumab, I typically do no labs. I will consider doing a TB test, but only if they have risk factors and only if the insurance makes me.
I know.
All these medicines were kind of grandfathered into this mandatory screening of TB testing based on the TNF-alpha inhibitors. And really, these drugs have long-term safety profiles that show that we really don't need to be concerned about TB with our IL-17 inhibitors, our IL-23 inhibitors, or IL-12, 23 inhibitors. And so my enthusiasm to put a kiddo through a blood draw for a test that I don't think is practical in a reasonable fashion, I tend to not unless the insurance makes me.
Okay, that makes sense. All right, I'm going to ask you some unrelated to psoriasis questions. Okay, so for warts, what is your go-to treatment?
Oh my gosh, this is magic, everybody. So there's a product called Wart Peel, and it's made by a pharmacy in Iowa. I have no vested interest with them. They just make a wonderful wart medicine. The pharmacy is called New Cara, and the product is called Wart Peel. And it's a combination of 5-FU and salicylic acid in a proprietary medium. And so the New Cara pharmacy has a patent not only on Wart Peel, the actual packaged Wart Peel, but also on the vehicle that the ingredients ride in. And I think there's something truly special about that vehicle because I've seen numerous compounding pharmacies try to recreate the magic that is Wart Peel, and often they sell it for cheaper than Wart Peel is, and it just doesn't pack the same punch. And I think it's because of the vehicle. It allows a slow dissipation of the active ingredients into the wart and produces the magic that we see from the product. Because Wart Peel works 98% of the time, doesn't hurt, works fast. Typically 3 to 4 weeks, you've got your warts gone. It is magic, and pretty much it's the thing I do 99% of the time in clinic.
And it's like $50?
It's $99.
Oh, $99, okay.
It is $99.
Which is cheaper than wart destruction.
100%. I commonly, I tell families this stuff works like magic, works 98% of the time, doesn't hurt. 3 to 4 weeks, you've got your warts gone. The only downside is the pharmacy that makes it doesn't deal with insurance. It costs $99, worth every penny. I think in general it ends up being the cheapest option for warts. You just pay it all up front,
Yeah.
But it comes with plenty. I routinely will tell families, do a wart check on all the other kids,
Yeah.
Because if, little Johnny's sister, Susie, has a couple warts, you may as well put the medicine to work there too.
Yeah.
And that helps make the cost a little bit more manageable too if you're able to treat 2 kiddos.
Yeah.
The only reason that you couldn't use wart peel is if you were breastfeeding or pregnant. And so I'll mention that in case mom's thinking about using it for herself and she's early on in pregnancy and doesn't, that sort of thing. So I will put that out there. And I also do caution families about keeping the medicine away from pets because 5-fluorouracil is very dangerous to dogs.
Yes.
And I'm a big time dog lover. Oh, I'm sorry, I pressed the microphone button. It's okay. Okay. I'm a big time dog lover. And so I don't want any doggies harmed by any medicine that I prescribe. And so, I mentioned keep it away from where a dog might find it. And once you apply it, put the sticky tape on top. Don't let your dog lick it because I certainly don't want to hurt any doggies.
Yeah. Okay, that makes sense.
Yeah.
What about molluscum? Anything new with molluscum?
Yes, there are a couple new things with molluscum. We had never had an FDA-approved treatment option for molluscum until last year. We got an FDA-approved version of cantharidin. We've known cantharidin forever. It's been around forever. But the consistency of the products we were receiving was highly variable. We were either compounding it or buying it from Canada or, the supply was always just a little bit sketchy. And sometimes you would get one bottle of it that worked great. And other times you get another bottle of it and you got 5 calls about extreme blisters. And then another time you get another bottle of it and nothing happens to the patients that you put it on. So there was a lot of inconsistency. It's nice now having this FDA approved version of it that we have efficiency, we have efficacy and tolerability that is consistent. We have a consistent formulation. And so that is a nice thing. So not a novel medicine, but a novel formulation.
Yeah.
And I like to joke, have you used Ycanth before? The new cantharidin?
I don't think I have.
So I like to say that Ycanth, which is the branded cantharidin that the FDA approved, that Ycanth is like, Ycanth is like cantharidin Taylor's version, like the original cantharidin, but it's even better. And the color of the product is this beautiful lavender color, which I call lavender haze. So I think there are Swifties working at the Ycanth company because I see Taylor all over their product. And we also got approval late last fall of a topical medicine to treat molluscum called berdazimer gel. It's a nitric oxide releasing gel, so it's going to be very interesting when we start to use it. It's going to come packaged in 2 packages, and the family will have to mix and apply right then because nitric oxide is a gas, so it dissipates. And so it'll be very interesting. It's twice-a-day application. Because of some logistical things, it's not going to be ready to officially prescribe until this fall. Okay. So we're still waiting to officially be able to prescribe berdazimer gel. But it's nice to see something else coming in, something topical that can be done at home. I think that's really great.
All right, what about vitiligo?
Ooh, vitiligo. So for the first time in forever, we have hope for vitiligo.
We have hope.
We have hope. And, it's gotten to the point where when I see a patient for vitiligo, I have basically zero enthusiasm to do any other treatments but topical ruxolitinib.
Yeah.
I just don't, the only reason to do the other treatments is to meet insurance criteria to get to topical ruxolitinib. But my optimism that topical steroids and TCIs are going to repigment the skin the way topical Rux does is basically zero.
Yeah.
Topical Rux is really the biggest advance we've ever seen for vitiligo. And it's giving our patients hope when they did not have hope before. It's particularly good in sun-exposed areas, so it works particularly well on faces, which is great because that's the most socially apparent area. And so we are limited to use it on less than 10% BSA. So I often will tell patients like what areas bother you the most, or I'll pick areas that are sun exposed because I think that's where we have the best expectation for improvement, and have them treat those areas. I think we're very hopeful to have an oral JAK to treat vitiligo because it can be challenging. Sometimes there's more than 10% BSA that bothers a patient with vitiligo, and so it will be nice to have an oral JAK to treat those patients. When I do prescribe topical Rux, I will always combine it with Polypodium leucotomus, which is an over-the-counter supplement that goes by the brand name HelioCare. It's over-the-counter, you don't need a prescription. We notoriously recommend it to protect the skin from the sun, but counterintuitively, it helps light therapy work better for things like psoriasis and vitiligo. And so we know that topical Rux works better with light works better with HelioCare, so I always recommend Polypodium leucotomus for my patients using topical Rux as well.
And not do a generic, right?
Correct. I always have them order the HelioCare, and I tell them there's regular HelioCare and there's HelioCare Advanced. You don't need the Advanced, that has the added niacinamide, and so the patients that I'm treating, they don't need that. And the regular HelioCare is a bit cheaper, so I say go with the regular. And the medicine can be taken, I mean, it's not even medicine, it's an over-the-counter supplement based in a fern leaf extract from South and Central America. But the capsules are big, and so a kiddo, you can open up the capsule and sprinkle the powder on food or in juice. I have a lot of patients that take it in orange juice every day. I use a tremendous amount of it for sun-sensitive conditions. It works amazing for polymorphous light eruption, for dermatomyositis, for the skin findings of dermatomyositis, lupus, juvenile spring eruption. Works really great for that. I use it all the time for that.
That's a good idea. Okay, so the topical Rux, if you stop it, do you see the pigmentation go away again?
Good question. So there's a 30% chance of recurrence post-repigmentation. And so there's a couple ways to go about this. One way is you could tell the patient to keep on using it. That's what they actually did in the trials. Out to 2 years, they told the patients just keep on using it even once repigmentation occurs. And so we know it's been studied that way, and we know it's safe that way. So you could just say, keep on going on. Another approach is that you can lower your risk of recurrence by integrating tacrolimus once the repigmentation has happened. So you repigment with the topical Rux, and then you switch to tacrolimus 2 days a week, twice a day, and it reduces the risk of recurrence to 10%.
Oh, wow.
And some people have asked, could we use topical Rux in that fashion? You know, so use it twice a day until you have repigmentation, and then continue topical Rux, but just 2 days a week, twice a day. It'll be nice to see a study that shows us it's that, you know, it's effective in that way. But for now, at least, we have data using the tacrolimus as part of a maintenance routine.
Okay. And I heard you had a trick for perioral dermatitis.
Yes, yes. So in kids in general, the treatment of perioral dermatitis can be a little bit different than in adults. Classically, I've given families 2 options. I've said we could do this topical pimecrolimus, which works about 2/3 of the time, so it's pretty darn good, but not quite perfect. Or we could do oral antibiotics, which work every time, but you have to take them for a month. That has been kind of my standard approach, and it does work well. It's a reasonable approach. But what I have discovered is that topical ruxolitinib works amazing for perioral derm, and faster than I have ever seen.
Wow.
You know, even when pimecrolimus would work, which I think it does work 2/3 of the time, it's a slower worker, you know? I've often told families, like, if at 2 weeks you haven't noticed anything, call me and we'll move on. But it can take up to a month for the rash to completely resolve. Topical Rux can work within days.
And you don't see a rebound?
No.
Okay,
No.
good.
It's pretty amazing. Now, the one hard thing is that, of course, that's off-label.
Yeah.
But a lot of patients with atopic dermatitis will get perioral dermatitis because of topical steroid use and things like that. So a lot of times your patient has that history, and so you can prescribe it for their atopic dermatitis and say, oh, if you happen to get a little bit of the perioral dermatitis, you can use it for that too.
Oh, that's perfect. I love your pearls.
Thank you.
Thank you so much for joining us today.
Thanks for having me.
Yes. Hope Cook with Dermcast.live.